says connecting at the top, and then eventually it just starts.
Oh, I see.
Yeah. Okay, great. I think that we're live. All right. Well, welcome everybody. I am so incredibly excited today to have this conversation with Dr. Regina Cruz, who is a integrative cardiologist in Long Island, correct? And we are both part of the Longevity Docs group, which is this collection of longevity doctors across the whole world. We have a very active WhatsApp group, and Dr. Cruz is always putting just the most amazing insights, and I knew that I had to have this conversation today to hopefully share some of that wisdom with all of you. But Regina, maybe I can just let you introduce the rest of yourself.
Oh, Jordan, well, thank you for having me and happy Friday. And,
That's
thank you for your kind words. I'm just trying to keep up with this, longevity doctor group.
yeah.
It's very interesting, very diverse, a lot of really great opinions. But I think it's fantastic to have you and a lot of other docs in that group because honestly, it pushes me to think about things, things that I've maybe taken for granted or, maybe haven't really spent much time explaining to other people. But, it really pushes me to say, hey, this is how we're supposed to look at it. And this is why we're supposed to look at it a certain way. And this is what we know. And this is what we don't know. And,
Mhm.
as you see yourself, there is a lot of room for improvement, right? A lot of room for growth.
Yeah, 100%. And honestly, it brings me a lot of confidence what you just said that even you can feel a little intimidated by the group because I because I feel like especially being relatively new to medicine in general, but also to this group, I feel always very scared to ask a question. um, but honestly, it's such a wonderful group, and I feel like everything you said is my favorite thing about it is that there's so much wisdom and there's so many different perspectives.
Mhm.
And I mean, the things that people talk about most of the time, I'm just Googling like, what even is this? But then I have this whole new insight into like new ways of taking care of patients and, thinking about how we prevent disease and how we help people live long, healthy lives.
Exactly.
Yeah. Um, well, I think, to start our conversation, both of us, I think, are very interested in preventative medicine and longevity.
Mhm.
And, I have a very strong sweet spot in my heart for cardiology. And I think that part of that is just, I find the heart to be just so physiologically interesting. But I think that another part of it is that, I really see menopause, which is, of course, my specialty, as a cardiovascular event. And I think that it's really an underappreciated part of that conversation. And
Mhm.
so, I know that you see a whole diversity of patients, but I'm curious,
Yeah.
for your patients who are going through perimenopause, menopause, like what are the things that are going through your head in terms of like, how do you risk stratify that person? What are the key things that you're going to be thinking about in terms of approaching that person's like cardiovascular assessment?
Yeah. So first of all, thank you for being interested in cardiovascular disease in women,
Yeah.
because what I find sort of difficult and a point of frustration for me is that a lot of the times we talk about women's health and we tend to bring women's health or view women's health through the lens of hormonal therapies, either absence of hormones or
Hmm.
adding hormonal replacement therapy, or of course through breast cancer lens, but cardiovascular implications and what cardiovascular risk factors and disease are in women's lives, unfortunately, we still don't discuss it. It's not at the top of our list. It is at the top of our list sometimes, but it's not at the top of our list all the time. And that's is upsetting because data is very strong is that cardiovascular disease continues to be the number one reason for
Hmm.
mortality in women.
Yes.
And so we should have this discussion. So I think your question is spot on. And, maybe the way to think about it, and hopefully your listeners will agree with this, is that we often say, but well, what's in a person's life is actually giving them a stress test, right? In cardiology, we're very big with stress tests.
Yeah.
And we could agree, of course, that pregnancy, for
Hmm.
example,
Definitely.
is that stress test, right? There is a lot of alterations in cardiovascular system and endocrine system It's a very, intense event, including the labor and delivery. And, a lot of the times cardiologists would approach a woman with that in mind, that pregnancy is cardiovascular stress test, and things that we see at pregnancy, whether it's, for example, pregnancy-related hypertension or preeclampsia or gestational diabetes, are the hallmarks or harbingers of future increased cardiovascular risk. What I think is missing from this discussion is that there is a second time in women's life, and being a woman and being a mom, I could, and being of a certain age, I could attest to all of these. But there is a second time in women's life when a stress test is taking place, and that's the perimenopause menopause transition. This is a cardiovascular stress test, which is very challenging because, unlike pregnancy, that sort of is an event which is time bound, perimenopause and menopause are not time bound. It's a very protracted phase in women's life, and obviously it's actually, for many women, gets, the onset of it happens when they're still very active, they're working, they're doing all of their things, and yet this is the arena of a cardiovascular stress test. So then the question is, who gets to pass the cardiovascular stress test and who doesn't? And that's where the entire risk estimate comes in. So I want to make sure that, our audience understands kind of how we think about it in cardiology. We always think about something called MACE, which stands for major adverse cardiac events. And, the typical ones are non-fatal myocardial infarction, so an infarct, but a person survived it, cardiac death, right? And any other type of an event that could be cardiac related. And depending on which studies you look, there are different events. Sometimes it's revascularization, whether a person got a stent or got a bypass surgery. Sometimes it's hospitalization and rehospitalization. But kind of the two really hard events are always our non-fatal myocardial infarction, stroke sometimes gets added into it, or cardiac or cardiovascular related deaths, right? So all of our risk stratification algorithms, if you will, that's what they are trained on. They are trained on predicting the likelihood of events in a certain period of time that are serious clinical events. And I think that's a very important point, because they're not trained, these cardiovascular risk estimators, they're not really there to detect early disease, right? They're there to forecast a really important clinical event. And so this is where often a disconnect is, because patients want to understand what is their risk of cardiovascular event, but the population-based risk scores are not set to really evaluate a specific person. They are essentially tied into the markers of population level risk, right? And so when you think about it, what forms the population level risk, right? High blood pressure, high cholesterol, diabetes, family history, these are obvious risk factors. We call them traditional risk factors, and they are found commonly in the population. And this is what forms the foundation of cardiovascular risk assessment, right? So the most recent one endorsed by the American College of Cardiology guidelines is a score called PREVENT. And it actually goes a step further, because it takes into account not only these kind of core traditional risk factors, but it also takes into account, for example, where a person resides. So it comes up with something called social deprivation index. It takes into account, or it could take into account, renal function, which is very important, right? Cardiac kidney metabolic syndrome. And so we are at the point where our concept of how we can actually strategize and understand a particular person's risk is being expanded. And that's a move in the right direction. But the tools are sort of lagging behind.
Yeah, it's so interesting, and I've never really thought about it that way, that, kind of these calculators are more of a population risk and not necessarily an individual risk.
Right.
Maybe this is a good opportunity to talk about the tool that you've created, because it's definitely something that I love, and I think particularly as a non-cardiologist, I find it to be so helpful, which is Heartwell.ai. So for any of the clinicians who are watching, you should definitely go check that out immediately. I think there's even a free version that you can do, maybe 2 patients a month or something. But what I love about it is that it really is thinking about much more of this individual assessment. So it has all of those traditional calculators that are built into it, but then it has a lot of other factors that go into it. Maybe, it's kind of a good segue to talk about like what are those other individual ways of assessing, one person's risk that start to go beyond what those population risk calculators are going to offer you.
Well, thank you so much for giving a shout out to Heartful.ai. It's my pet, it's my baby, and for being the early adopter. And yes, absolutely. We actually have a free version that includes all the platform components. No one is left out because this is for people who don't have potentially too many patients. So you can always have like 2 patient assessments per month, and you get full version with the full AI support and everything that comes with it. So the way to think about it is that how do we, as you were saying, Jordan, how do we bridge that gap between the population risk estimate, which is still what we have in cardiology. It is proven, it is tried and true, and this is so-called deterministic risk, right? We have populations that were studied, there were certain events were observed, and these equations were derived from these observations. Those were fundamental studies like Framingham Heart Study, for example, and so on and so forth. But we know also that there is a bit of a paradox in cardiology because, for example, while we put a lot of emphasis on lipid levels, we know that 50 to 70% of patients with their first myocardial infarction have normal cholesterol, right? And so where is that disconnect? And as an integrative cardiologist, after working with hundreds of patients, literally, and doing a lot of work and reading into it and thinking it through, I think we can narrow it down to some really important things that pretty much anyone can get because they're not esoteric, they're not, some sort of a research. But so what are these? First of all, genetics and genomics, right? So we can easily get medical grade genetic assessment of our predispositions to cardiovascular disease, including evaluating the pathways that not only lead to heart disease, but lead to, for example, Alzheimer's time dementia, and even some longevity pathways. And, I know we're going to have a discussion on genetics, so we'll go a little bit more into it, once we pass like this initial setup. The second really important component is while we certainly have biomarkers, blood biomarkers, and there is no shortage of those, one could easily get huge panels like function health and whatnot. When we have those biomarkers and when we do have genetic information, the question then is, how did it impact an individual right now, right? Because one person may have a genetic predisposition that places them at intermediate risk, and another person may have equivalent predisposition putting them at intermediate risk, whether it's with blood or with genetics together. But we are finding that in individual A, that somehow leads to accelerated atherosclerosis, and in individual B, they're actually essentially disease-free or almost disease-free, right? So there is this disconnect. And so how can we figure out what is the impact of blood biochemistry and genetics on a person in front of us? And that's where cardiac imaging comes into play. And, in cardiac imaging, I think have gained a lot of ground because we have coronary artery calcium score. We certainly have CT angiography. Now it evolved into AI-assisted quantitative angiography, so we can see, the plaque composition. We are literally at the threshold of inflammation imaging. It's actually already, pericoronary fat inflammation imaging has been done in European Union for at least 5 years at this point, is just about to launch in the United States. So I think we can finally, for the first time ever, we can connect the dots. And when we connect the dots, all of a sudden, we're going to go beyond these sort of foundational population level assessments, which at their best are a crude estimate of what your patient potentially may be facing. And we're actually going to get, and this is what we do with all of our patients at the holistic heart centers, we get a detailed map that is our plan of action. What can we change in that individual based on their genetic makeup, based on their rate of vascular disease aging, right? Because you heard me say this all the time, longevity is vascular. Of course, because, I hope Brian Johnson is listening and his coronary artery calcium score is 0 and he has 0 soft plaque anywhere. And, his arterial stiffness is the one of a 30-year-old. If that's the case, I'm going to say, Brian, your stuff works. But if that is not the case, then we have to figure things out and do things a little bit differently. So that's really the framing. And, a lot of other stuff, which you're doing and I'm doing and doctors in our longevity group are doing comes into play. Oxidative stress, toxic exposures, hormonal imbalances, impacts of stress and sleep. These are all things that connect. But fundamentally, we have to have sort of this, this triangle, advanced biomarkers, genetics, and what do we see in the vasculature? How these two compute, the inputs and the outputs.
Yeah, no, totally. I love the framing of that triangle, because I think that's exactly how, I'm usually thinking about it, but obviously don't have the depth of knowledge that, somebody like you would have. To get into the imaging a little bit, I think that, it's kind of a common conversation that comes up with my patients. And I think that just a lot of people are, hearing more about this, and they're sort of hearing like, oh, I can do a clearly angiography, or I can do a coronary calcium scan, or I can do a CIMT, which is an ultrasound of the carotid arteries. Like, how do you usually think about approaching that conversation? And do you have kind of a preferred imaging to start with for people? Like, how do you approach that usually?
So, that's a great question, because I think any type of cardiac imaging had always be taken in context, right? The traditional cardiac imaging, sort of the imaging that I grew up with when I was, in your shoes and just, fairly early in my career, was all directed at detecting obstructive stenosis, right? So it was all focused on that late stage disease where one could potentially do a coronary stent or maybe bypass surgery. But then the imaging evolved to actually allow us to understand subclinical or preclinical atherosclerosis, the one that has not materialized into any symptoms or into any events. And this is where we have to balance what the imaging is going to show us and what are the negative impacts of this imaging modality, as well as, is this the imaging modality that you can use, for example, longitudinally, to give you an understanding if the efforts that a patient is making are actually impacting them greatly and moving in the right direction, or they're actually not having much of an impact, right? Maybe a patient is not doing what they're supposed to be doing. So coronary artery calcium score has extremely robust evidence behind it. It is an easily available test. Even without insurance coverage, it is fairly inexpensive. And this is something that almost anyone ages 40 or greater could easily get. And actually, for the first time, in ever, the ACC guidelines for lipid management, they just come out in 2026, have decided to put coronary artery calcium scores into the equation and kind of understand where things are supposed to be, right? And so that's one sort of thing. But the problem is that there isn't really longitudinal assessment for coronary artery calcium. If a person scores in the best category, and the best category's calcium score is 0, right? We could potentially repeat a score in 5 years, because we know that a certain amount of people, up to 20%, may actually now change their score. It will become a non-zero score, right? So that's sort of one part of it. Another part of it, when the scores are significantly increased, a person does have a higher rate of those MACE, of those adverse events, and they may require additional workup, just to make sure that, we're not missing anything. And the young people below the age of 50, predominantly tend to have very small scores, or scores of 0, because at those, younger people, their plaques are predominantly soft, right? So then another question comes in: should we search for soft plaque? And that's where I think things get a little bit more challenging, because to find soft plaques, or any type of plaques other than strictly calcified ones in the coronary arteries, one needs to do CT angiography. Now, CT angiography is an exam where radiation exposure is higher than for coronary artery calcium score. It does require intravenous contrast. Usually, most people will not have contraindication to that. It does require preparation because we have to make sure that the heart rates are low enough for
Right.
imaging and so on and so forth. So it's a very useful test that has some prognostic data attached to it as well. It is essentially repeatable because we could repeat it, let's say in a couple of years for a very high risk patient, or a little bit later for less riskier patient. And now for the first time, we have those two absolutely amazing tools. So one is the AI quantitation, which is so much better than just eyeballing and saying,
Yeah.
oh, there's this much or that much. And the second tool, and AI quantitation doesn't only tell us about plaque composition, it also tells us about flow. So there's two components to AI quantitation. And a third piece, and it is a separate second modality, is the ability to image inflammation around the arteries, right? So these three pieces of information are very powerful because they redefine essentially what we would get from just, clinical assessment, biomarkers. And what we are finding is that patients who are in a genetically riskier categories are actually showing us that their coronary CTs are revealing the soft plaques. Now, the modality that I personally love to use, and I use it with many of our patients, is CIMT. CIMT stands for carotid intima media thickness. It's an ultrasound test, and ultrasound test is essentially benign. It's just the ultrasound waves. It's something that could be repeated every 6 months, and usually we repeat it 12 to 18 months because we actually want to see some real changes. And it takes advantage of the fact that whatever is happening in the carotid arteries, 80% of the time, the same thing would be happening in the coronary vessels as well. So we can forecast an understanding of where a person is and kind of plot their vascular aging curve based on this. And of course, there are other measurements which are technically wouldn't fall, I guess, into the arena of cardiac imaging, but I already mentioned arterial stiffness. So there is actually, kind of in Heartwell.ai, we're working to build a multi-domain vascular age estimator that would take into account, the calcium score, the ST angiography, CIMT, arterial stiffness, or other indices sort of arterial stiffening. There are several of them, and provide this composite vascular score that would give a patient sort of a range of where their vascular age is, right? And it's all adjusted based on their age and gender, because obviously as we get older, we develop more abnormalities. So there is an age adjustment, it says gender specific because, men and women don't age in the same speed, so there is all these sort of permutations that come into it. But I think the cardiovascular imaging, whether one defines it narrowly as literally seeing the heart or vessels in whichever way, or just doing the functional imaging assessment, which is what arterial stiffness measurements usually do. That is a huge opportunity to really tell a patient how aggressive they may need to be with their treatment.
Yeah. And I think it's always an interesting conversation, like particularly for me, that radiation element of things, because, I think that we really need to be very thoughtful, just like you said, about like, what is the information that we're trying to get from this? Because, I think, that another very strong, area of passion for me is breast cancer prevention and, and then dealing with menopause after breast cancer. And I worry about young people, getting a CT angiography, it's not really going to add a whole lot of information, maybe if they're a particularly high risk person, or we're really kind of, trying to make an assessment of what is their current stenotic burden. But I think that, we need to be thoughtful about those side effects. And, I honestly haven't used the CIMT as much, but I've been, a lot more thoughtful about that ever since you started talking about that, because I think that it is such a great tool, from my, assessment of that. So.
Right. And I think you are completely correct in being careful about CT angiography in young women, because there is small but statistically significant increase in breast cancer risk with, CT acquisition across the chest. So,
Yeah.
we don't want to compound to a problem that we already see rising, from the point of view of imaging. So it is important. So responsible use of imaging, I think, is really critical because, and it's not that one modality has to exclude the other, but I think we need to adjust what we're doing, not only based on a patient's level of risk, but also on the harm that potentially could come with imaging.
Yeah, totally. Well, I think this is a nice transition into that last element of the triangle, which is the genetic testing, which again, is I think something that you do so well and you talk about so well. So how, I guess just generally, like maybe you can give everybody a general overview of like what are really the broad categories of genetic abnormalities that we're looking for here, and what are like those big players that are going to make the biggest difference in terms of how you would actually approach managing somebody's care.
Yeah, so great question. And I think, it's here's the situation as we see it, right? So genetic testing in kind of conventional cardiology has still been primarily delegated to some very specific conditions, right? So for example, certain congenital arrhythmia type of syndromes, they typically would go through genetic testing. Some other genetic testing that is related to structural heart disease abnormalities. Here, we're just going to focus on genetic testing as it relates to the propensity to develop coronary atherosclerosis and have cardiovascular events.
Yeah.
And the frame of reference here is that, there are kind of a couple of, maybe paradoxical things that is happening, right? So many patients come in and they say, "Oh, doc, give me the drug. I know my cholesterol is high and I know it's genetic." Right. So, I'm sure you heard that before. People say,
of course, yeah,
it's genetic. My mom had it. My dad had it. Whatever. They all had it. Right. So, and then there is another part of it. The related part of it is that patients come in and say, well, I want to get ahead of the curve. I want to be very preventative because I do have a family history. And, family history is a bit of a black box because, yes, there are relatives, especially first-degree relatives who may have had heart events when they were young, but it's also a different generation, different patterns of eating, different stress exposures, and everything else, right? So how should a practitioner then, if they want to implement genetics, how should they think about it, right? If they are encountering these patient situations. And so we make a distinction between monogenic and polygenically defined risk. And for many, many years, for decades actually, cardiology operated strictly into this monogenic environment, meaning like a single gene, right? And that was a domain of lipidologists. Very often, they would see patients who were born with a single gene or a couple of genes that had large effect size, and phenotypically these patients would exhibit abnormalities. Let's say they would have elevated cholesterol as young children, elevated cholesterol as young adults, and this condition is known as familial hypercholesterolemia, and this is a classic monogenic condition, right? The issue is that while it is a very significant clinical condition and markedly increases people's risk of cardiovascular events, and the same is true for lipoprotein little a, we don't have as many people with familial hypercholesterolemia as we thought maybe initially, right? So we know that maybe like 1 in 250, let's say 1 in 300 individuals would have some genetic marker for familial hypercholesterolemia. And usually what I tell my patients, I call them big bad genes, like big bad wolf, right?
Yeah.
Like this one marker and boom, you'll see your
That's it. Yeah, exactly.
That's it. It goes sky high, right? But what the data actually shows is that majority of heart disease is not caused by these big bad genes because they're just so uncommon in the population. Majority of heart disease, and we have these data from biobanks, is driven by multiple genes, and typically we call them variants of uncertain significance, just like genetic official language, which is a little frustrating, but it is what it is. And so these multiple genetic factors, each of them may have a much smaller effect size, but when combined in a specific sort of assortment, they could place an individual in a higher risk group versus a group of people. Again, we're back to some population metric that comes historically from the same region of the world, right? And this is called polygenic risk score. So
Mm-hmm.
typically, if we see a person in a top 10%, top 20% of the polygenic risk score, we would say, well, that's a high risk because 80% of people are actually below that cutoff. And this person is so much higher. And so this actually is much more common because if they are in the top 20%, that means 1 in 5, right?
Yeah.
Not 1 in 300, 1 in 5. And so if you look at it through this lens, then you start to understand why cardiovascular disease and vascular disease in general is so highly prevalent, right? And continues to be the number one killer of men and women because we have these combinations of genes where 1 in 5 may actually be in that higher risk group. And so investigators have started to look into it using the cardiac imaging perspective, right? Because if a patient may say, well, okay, I'm in that high risk group, so what? Like it is what it is. These are my genes. But so what is does actually have an answer? Because there was a recently a very interesting study. It was called PROACT, and it was looking at the individuals who had genetic makeup analyzed in Massachusetts General Hospital, and they identified people who were scoring very high in these polygenic risk markers, right? They were like top to 20%, I believe. And they invited those individuals. It was a free test. They wanted them to have CT angiography, right? Test we just discussed. And so people came in, approximately 200 people came in for that CT angiography. They had no symptoms. Their population-based risk scores, traditional risk scores, were super low. They did not have elevated cholesterol. You would not give them any drugs. But half of them had soft plaques on that cardiac CT, right? So now all of a sudden, we need to kind of reframe our thinking and say, hey, maybe what we should be doing, and this is the approach we created at the Holistic Heart Centers, and this is how Heartwell.ai came to be about. Maybe what we should be doing is that we should be putting genes first, right? Because if they have such a profound impact, then that redefines the treatment strategies. Because someone whose LDL is 70 and ApoB is 80, but they have soft plaque and they're only 50, and they're in that high, 20% polygenic risk score group, this would be a person where I would drive the LDL to less than 55, right?
Yeah,
I would look very aggressively for inflammation and oxidative stress and hormonal imbalances because I know those are the feeders into atherosclerosis. So I think this is where the shift needs to happen in people's minds. They need to embrace the fact that genetics is very powerful. And even the official guidelines, again, the lipid guidelines do bring up polygenic risk scores as something that should be taken into account. So we don't necessarily have an algorithm yet, but we have a recognition that these things are powerful.
So, I mean, it's so fascinating. And I love that idea of you lead with the genetics, and especially, I think, going to what we were saying before about, maybe some of the potential risks associated with the imaging modalities. So I guess that's kind of my question is, if you have somebody who, you get their polygenic risk score and they're in this higher risk group, do you still even pursue imaging in that person, or do you basically say, like, listen, you're in this high risk category, yes, the imaging might change us a little bit, but overall my goal is still going to be to get your ApoB as low as we possibly can get it. I'm just curious, like, how you approach that situation.
It's a great question, and I do pursue the imaging because as we know, as powerful as genetics is, it is not the type of genetics, for example, which has a dominant phenotype. So we may be in a situation where a person is in that high risk group, but they have no evidence of early coronary disease, right? And so this could be somebody where the target's a little bit more permissive, and they go to get monitored serially in terms of their vascular status and their functional status, to the point where we may potentially figure out where we should intensify management, if at all, right? So they kind of have a longer timeline, as opposed to someone who may have exact same blood markers, and also in that high risk group. But now we go into cardiac CT or we do CIMT and we see that atherosclerosis is accelerated, right? They are ahead of their age group, of their gender with regard to atherosclerosis. Now, that's a person where, as much as we try to, of course, lean into lifestyle and supplementation, and that's, it's the core, it's the foundation. This is a person where medical management, pharmacological management may actually protect them for the future.
Yeah.
So this is a very important decision-making point.
Yeah. Does having a high polygenic risk score influence which imaging modality you're going to choose, or does it go into kind of the same discussion that we had earlier?
It does get attenuated by that same discussion. And, typically I like to get a baseline calcium score, and depending on a patient's situation, I may get a baseline CTA that's not universal. But I feel like imaging modalities that are much lower in terms of their negative impact, like CIMT or, arterial stiffness measurement, which is like a fancy blood pressure measurement. Some people like to do, for example, endothelial dysfunction measurement, although that one is a little bit more difficult, less standardized. Those are easy enough to get, and they have lend themselves easier to longitudinal follow-up that could allow a patient and us decide how successful they are and the strategies that we're implementing, or do we need to pivot? So one could sort of create an opportunity for each patient to get the right type of imaging for their specific risk category, but also built into it not only the baseline, but the opportunity to follow them over time.
Yeah, no, I love that. Are there any monogenic tests that are still very high yield? I mean, of course, the familial hypercholesterolemia, I can imagine that. But I guess what I'm thinking about is that, like with Lp(a), for example, I've heard that, if somebody has the genetic marker for Lp(a), that might influence a different pathway compared to just having the phenotype of an elevated Lp(a).
I agree 100%. And actually, Lp(a) is much more common than we thought, again, right? And it's finally, for the first time, is really figuring itself out in the guidelines, but up to 25% of the population will have it. And, especially when it comes to women that go through perimenopause and menopause, we are seeing anywhere from 15 to 30% jump in all the lipid markers.
I see that all the time.
All the time. I see that all the time. And I think, there is another part of this sort of discussion, which is very intense and we don't have great answers, is that the hormonal replacement therapies don't necessarily lower these markers. And even if they do, we don't necessarily have the outcome data to support that was beneficial for cardiovascular outcomes, right? So there's a lot of uncertainty, but definitely, Lp(a) genetic testing, and these are monogenic tests, very impactful. Another monogenic tests that are very impactful include something called 9p21. It goes by a different name now, but it's essentially a gene related to smooth cell muscle proliferation in the coronary arteries, so related to endothelial dysfunction, right? So it's a non-lipid factor, right? And I think the monogenic factors are impactful not only for familial hypercholesterolemia, but for figuring out what are the pathways that may be driving this patient's atherosclerosis. They're not all lipid-dependent pathways, right? So lipoprotein(a) is, ApoE is, but 9p21 is not a lipid-related pathway. And then there are others, obviously, that have to do, for example, with methylation and oxidation. So they're sort of maybe not primary, but more with secondary ones. But again, they're non-lipid related pathways, right? Insulin resistance genetics or beta cell dysfunction genetics, again, it's monogenic, both monogenic and polygenic. Most people are not going to have those big bad genes, but they may end up, let's say, in the top 10% for insulin resistance. And we know that is going to drive atherosclerosis, right? So there is a lot of, genetics is not only an opportunity to act, but it also tells us how to act, right? Because we can prioritize things based on how individual pans out in terms of their genetic makeup, right? So the genetic makeup cannot be changed, but genomic influences, what we do with it, could be changed on a daily basis.
Yeah, that's really cool. So kind of what I'm hearing is that the polygenic risk score like really helps you frame this individual risk stratification for that person, but then you still need to see like what is their phenotypic expression, and maybe the imaging is going to help guide that. But then those monogenic pathways, those individual genes are going to maybe give you a little bit of a hint of what is the primary pathway that you want to address here in terms of actually decreasing this person's risk in the future.
Exactly. And how? Because, there are also genetic markers, and again, they're monogenic, that would tell us if a patient is likely to have a good response or not such a great response with commonly used medications, such as statins, right? So we want to try to figure out the most personalized solution that makes sense, because then chances are that a patient will stick with that solution. It will be acceptable to them, and we are able then to drive successful outcomes down the line. So there's a lot of power, the interaction of, biometrics, biomarkers, genetics, and imaging assessment.
Yeah.
Maybe it should be a square, not an I don't know.
That'll be the next version. Exactly.
Next version.
Yeah. Well, I think that what I love about it, because I think that, I think a lot of people are just naturally very interested in genetics. I think that there's a lot of promise that genetics poses. But I think that what, this conversation, and I think what we really should always be very thoughtful about, brings up is that genetics really has to be very targeted. You have to have a very clear question that you're asking, and you have to have, an answer that you're hoping to get from genetics. It's really easy to say, we're going to profile your whole genome and we're going to see what pans out. And most of what you get is noise, and things that aren't actually helping you guide. But I think that like the pharmacogenomic element of things is so interesting to me. Like let's make sure we're starting you on the right medication from the start and not doing this trial and error. Let's make sure that we understand actually exactly what pathway might be driving your atherosclerosis, and is there a particular intervention we can do based on that. So I think that actually cardiac genetics in a lot of ways is sort of the most perfectly targeted version of this, because it does give much more clear answers than you might get in anything else.
I agree. And, and I think I also sort of early on when I started my practice, I was a little bit disappointed in genetics because, most of it was kind of leaning more into nutritional stuff, and it was okay. It was helpful to a degree, but there wasn't like sort of like a big aha moment, right? But then once the polygenic scores came in, and once I realized that there are actually vendors that are able to give us genetic sort of pathways, or strings or buckets, whatever you want to call them, but let's call them pathways. And you think about the physiology of these pathways, that's where one could actually make a real difference.
Yeah. I don't know if you feel comfortable sharing, like if there's any particular testing companies that you like, but if you don't feel comfortable with that question, I guess for the listeners, I'm curious, like if somebody's asking like, how would I get this done? Or like, what does it cost? Like kind of like, tell me maybe about the logistics just for people who are interested in this.
I'm very comfortable sharing. I use a company called GB Insight. They're a medical grade genetics company. They work with a lot of lipidologists and cardiologists, primary care physicians. I believe they're primarily available in the United States. I don't think they're available internationally. Another company that is worse people investigation is called Intellex. And so Intellex is also primarily United States based, but they do have an offering for European Union, which is actually cardiogenomic offering. So that's potentially good. Vibrant recently launched a test called CardioZoomer, which does have a related genetics panel, which is also very helpful. It is not PRS. So the GB Insight is the only one, to my knowledge, that provides PRS, which provides a pathway-specific PRS. The other two companies, as far as I could tell, only provide monogenic markers. They're not really technically computing polygenic risk score. But there are other providers. Boston Heart has a partnership with Allelica, and they will provide a polygenic risk score.
Yeah, I've used their test before.
Yeah, you can use their test. There's something called color genomics. So there's a lot of options, I think, that patients have. I think most important is, if someone is interested in this, they need to find a doc who can be their guide, right? Because it gets overwhelming, confusing, and expensive. These tests, luckily these tests right now, at least, GB Insight is available. It's less than $1,000 and you do it once, so this is really helpful test. And when the new markers come into the mix, the genetic profiles get reanalyzed. So this is also very helpful. And I think the issue always is that I don't want people necessarily to jump and say, oh, I must have genetics or else. But, this composite complexity of cardiovascular risk is always at the top, right?
Yeah.
Because, and that's what we can't lose the sight of that.
Yeah, totally. And I think, just to give another plug to the Heartwell.ai that you developed, I think what's really cool about it is that if you have this genetic information, you can input it into there, and then it will modify those population risk estimates based on your specific situation. So again, I mean, I see this being such a good tool for everyone, but I think particularly for the non-cardiologist, it makes it so straightforward to really figure out. And then, the other really cool part that I love is you can make that report of, if we add this medication or if we add this supplement, it will modify it in this way. So yeah, I just find it to be so impressive, and I'm really happy that you put that together because it makes it much easier for people like me.
I'm happy for you using it, and thank you, because and I do encourage people, if you're a physician, you do need an NPI number, because this is how we know that you actually are a doctor and not a patient trying to simulate your own medications, which we don't want to do at this point in time. So it is available primarily to US-based practitioners at this point in time, but our chat with case feature is very powerful. You can ask questions against genetics, against laboratory data, and now that we're working on putting agents in there, it will become will be a little bit more in depth, and you'll be able to truly get personalized guidance at the point of care, which is what as I told one founder recently, is that the database is here and I'm trying to take it over there. So so that's what's happening.
Yeah, I love that. Amazing. Well, Regina, what are the best ways for people to find you, either to follow your content, or maybe, I don't know if you are open to seeing new patients, but how can people find you after this?
Always open to seeing new patients. Our website is holisticheartcenters.com. We have, a little widget on it that you can speak with the conversational AI, or there's a phone number on it. You can text us and we'll text you back pretty much right away, or just call us and we'll call you back right away. My newsletter for holistic cardiology, integrative cardiology, is actually on LinkedIn. It's called the Holistic Heartbeat. It's 100% free. My Substack is primarily free. It's called Vital Signs and Bottom Lines, and I know you're subscribers, so thank you. And Vital Signs and Bottom Lines is more about AI and digital health and technology, and how that factors into what we're doing, whether it's integrative cardiology, integrative GYN, or longevity, so that's sort of like another part of me that, I find I'm fascinated with technology, and I'm always looking for ways to apply it.
I'm sure that will be a future conversation that we'll have. So I look forward to it.
You got it.
Yeah, amazing. Well, thank you so much for your time today and your wisdom. I think that this is going to be really enlightening for patients and clinicians alike. I know I learned a lot, and I'm excited to, start to incorporate some of these things into my practice even more so. So
go for it. Thank you, Jordan.
All right. Have a good weekend and rest of your day.
You too. Take care. Bye. Bye.